Okay, so hi everyone, I'm Taylor. I'm gonna be giving my senior lecture today. Hopefully everyone knows me by now. I'm gonna be giving on some PEM pearls. I was trying to find another topic, but I was like, who am I kidding? What else am I gonna talk about besides PEM? I tried to compile some pearls that I've learned from the many mentors, nurses. You'll kind of find their credit at the bottom of the slides. And hopefully you can take one thing away from my lecture to use on the pediatric side. And I'm sorry if I'm repeating stuff that people already know. Okay, so this is not a trick question. What are our favorite medications in peds? Yes, okay. So yes, Tylenol, Motrin. So just to set up the scene, your patient has Defer-Vest, you handed the discharge papers to mom and you're walking out of the room and she asks, but how much Tylenol, Motrin should I give at home, doctor? So I know a little boring, but I'm gonna go over some dosing. So you have a 10-kilogram child. Quickly, off the top of your head, how many mLs of Tylenol and Motrin are you gonna tell them to give? Yes, okay, good. So if anyone knows me, I didn't do this math in my head, and no, I didn't use pedestat. But when Sinnert says that there must be a God during his acid-based lecture, this is the moment in peds. Because for both Tylenol and Motrin, the mLs of the child should receive should always be half their weight in kilograms. Just remember it's mLs, not milligrams. Just to show you that this works, for a 10 kg child, 15 mg per kg for the dose for Tylenol, 5 mLs per 160 milligrams for the concentration, you get about 5 mLs. And for Motrin, 10 kilograms for 10 kilogram child, for 10 milligrams per kilogram dose, for 5 mLs per 100 milligram concentration, you get 5 mLs. Just to show you that it works again, for a 30 kilogram child, get 15 mLs. Here's the calculation. It starts to get a little less accurate for Tylenol above 24 kilograms, but when the child probably spits out 1 ml here or there, it's not really gonna make that much difference. So you're about to walk out again and mom asks, but do I buy infant or children's Tylenol, Motrin? The quick kind of answer is that you should always say children's, and this is why. For infant and children's Tylenol, it is the same concentration, and the same price. So for infants, you're getting about 60 mLs. For children's, you're getting about 120 mLs. So for more bang for your buck, you should go for children's. It's important to note, though, for Motrin that there are different concentrations. So for infant, it's 50 milligrams per 1.25 mLs, while children's is the typical 100 milligrams per 5 ml that we know of. I'd heard that they were supposed to take the infant Motrin off of the market, but because of confusion and there's a lot of incidents of overdosing, but I was still able to find these on all kind of online and all big kind of drugstores. There used to be, yeah. Yeah. That I did not look into. And again, these are also the same price. And for 30 mLs versus 120 mLs of medication. So you're better off advocating to purchase children's. You'll have more medication. You can use it for all the age children in the household, and there'll be less confusion from what their doctor is recommending that they give. So I know I just taught this kind of trick, something off the top of your head, but again, during a resuscitation, this is not the time to kind of be flexing your memory of dosages. I'd recommend you use a resource. I personally use pedestat. And during resuscitation, you may not always be able to weigh the child. You can always take out the Broslow tape, but I've been in situations where there's multiple resuscitations or like an MCI event, and you may not have enough Broslow tapes. So you can use this equation at the bottom, or you can use pedestat. It has a more sophisticated way to predict the weight of the child, and you can kind of look in their reference section for how they do this. But pick to a weight, stick to it, write that weight on the bed or even onto the child so that everyone kind of is on the same page about dosing. So I think everyone has a little bit of hesitancy when they come into pediatrics, but I wanted to take a few slides to emphasize that all the skills that you've acquired on the adult side all apply in pediatrics as well. So we all know the importance of history. 80% of history is what leads to our diagnosis. And just from being ER doctors, we know when something doesn't make sense. So trust that kind of gut instinct. This may be even truer in pediatrics, and sometimes small details that don't make sense can help you diagnose pretty dangerous conditions. So I'm just going to go over kind of 3 examples in my past 4 years of this. The first one was a 9-year-old male. He had no medical problems. He came in for epistaxis that had resolved on arrival. It was a super busy room, and the attendant was kind of like, just get them out. But in the history, he had told, mom and him had told me that he had to take breaks while he was walking to school. and he only like lived 5 or 7 blocks away from school. So I kind of begged and pleaded for a CBC, and he ended up having myelodysplastic syndrome, and he required a bone marrow transplant. The next one was a 7-year-old female. She had no medical problems either. She came in for a splinter. Spoiler, it was not a splinter. It was a plantar wart. But she would not go on any rides at the amusement park yesterday, and she slept on a bench the entire day while all the other children went on the rides. On further exam, she had a strawberry tongue. Her palms were red and swollen with peeling, and she had conjunctival injection. She actually had partial Kawasaki's with a coronary artery aneurysm. And lastly, 4-year-old, history of febrile seizures in the past. He came in for fever and kind of tiredness after having a seizure 6 hours prior to arrival. The concern in the room was initially for febrile seizure and kind of to treat fever and watch him. But then mom described an episode of his legs giving out when he was going to the bathroom, and he refused to walk after that. That was even prior to the seizure. So due to that kind of small detail in the history, decision was made to line and lab him initially when he arrived, and he shortly afterward went into septic shock. His blood cultures grew back Neisseria meningitis. So that kind of small part in the history kind of made us change our management for what we thought was a simple febrile seizure. Also important to note that the post-ictal stay for febrile seizures is usually shorter. It should kind of be less than an hour. And if it's kind of prolonged, you should consider doing more. So I think it's really been emphasized to us on the adult side that we should look at all of our imaging and not just rely on the radiology reads. So this is another kind of case of this on the pediatric side. This is a patient that was signed out to me. 4-year-old, had history of autism, presented for abdominal distension for 2 days and decreased appetite, was still drinking fluids, no vomiting. Last bowel movement was yesterday, no viral symptoms. On arrival, had a temperature of 101.8, was tachy to 178, but otherwise normal vitals. She was kind of a difficult exam because of her autism. She didn't want anyone to touch her. Her abdomen was distended. She was kind of holding it rigid, so you couldn't really palpate deep. Decision kind of close to rounds was for an x-ray and kind of a plan for an ultrasound as an ultrasound attending was coming on. This was the read that we got back. It said non-obstructive bowel gas pattern with no evidence of pneumoperitoneum. And just to let everyone know, it was also finalized by one of our favorite radiologists. But this is the picture that Dr. Rollo pulled up. Kind of showed everyone in the room. Do we think this is a normal x-ray? No. So yes, there is paucity of bowel gas on the right side, and you can even kind of see at the bottom here on the screen, you can almost see the outline of a mass. So again, we told them to addend their kind of read and kind of did an ultrasound, could kind of see that this child had a large kind of tumor. Child ended up having a Wilms tumor, was transferred for chemotherapy and resection. So again, importance of viewing your own imaging on the adult side, but also in pediatrics, would say maybe it's even more important as you don't know the radiologist's comfortability with peds x-rays, and we're ordering a lot of abdominal x-rays that they don't typically look at on the adult side as much. So I'm also going to set the scene for you. It's the middle of the night. You have a 4-year-old. They come in respiratory distress. They have a history of asthma. They have multiple PICU stays, history of 2 intubations, 1 in the last year. They're grunting. They're barely moving air. They're head bobbing. You have 2 adult nurses. They are able to get an IV. You overhead respiratory. You get the patient on BiPAP. You can take that as a good or a bad sign. And you order these medications. Is there any instructions to the nurses, the adult nurses, on how you want to administer any of these medications?
You're gonna have to step on the face.
Okay, good. But anyone?
120 beds.
Okay. Anyone else have any thoughts? So the answer is actually Solumedrol. If you don't want this to happen into the BiPAP, you gotta tell the nurses to push the Solumedrol really slowly. You can also put it in a 25 cc bag and drip it in slow, but that might not be best in this child who's sick in the resuscitation room, but very slowly. I couldn't find anything in the literature about this, but all the pediatric nurses know this, and there's plenty of non-published articles regarding this. So, and I have witnessed this myself. I had a child in BiPAP vomit right into it. It's not a pretty scene. So tell your nurses, push the Solumedrol slow. So let's just say you're with Con during this resuscitation and she reaches for terbutaline instead. And you're kind of like, what are we doing? How do I do this? So I just want to talk a little bit about epi versus terbutaline versus mag. There really is not good evidence for epinephrine or terbutaline versus terbutaline even in adults and definitely not in pediatrics. So just to remind you, epi is an alpha-1 and non-selective beta agonist, and terbutaline is a selective beta-2 agonist and has some effect on beta-1 at high doses, which is kind of why we max out at 0.25 mg. They can be given without an IV, which is really useful. The IM dose, you give epi IM, 0.01 mg per kg per dose. You can give it every 20 minutes and repeat for up to 3 doses. Typically, it's never really followed by a drip in pediatrics unless you're concerned for something else like shock. Terbutaline is given sub-Q, 0.01 mg per kg per dose, max dose of 0.25 mgs. As if you push higher than that, you kind of have the adverse effects of it. And it's given every 20 minutes as well for up to 3 doses, and you can then start a drip. Your decision to give these may come down to kind of the adverse effects of these medications. So for epinephrine, as we know, kind of can cause anxiety, jitteriness, tachycardia, and cardiac arrhythmias are the major kind of adverse effect. And those are only going to be exacerbated in patients already receiving albuterol. And if epinephrine is given, the level of tachycardia may preclude you from then starting a terbutaline drip. Terbutaline also causes that nervousness, jitteriness. It can cause tachycardia, but it's generally less than epinephrine, but it can cause hypotension in children. So if you're going to give, you may have to hold on the magnesium, but you should always prioritize this medication over the magnesium. As we know, magnesium causes hypotension and should be always given with a bolus, but if your decision to give epi, then you can kind of start the magnesium. So overall, you may want to consider terbutaline in a patient that comes in extremely tachycardic or has a history of SVT in the past. But typically, from kind of speaking to everyone from the EM standpoint, it was going to come down to your comfortability and timing. Typically, you can get epi a lot faster. The nurses are more comfortable with it, and we are pretty comfortable with epi and mag, so that's most likely what you should do. So again, set the scene. It's a busy 3 to 11 on a Monday, and 3 rashes pop up on the board in the asthma room, and you pick them up hoping to dispo them quickly. So the first one is a 6-month-old with diaper rash. You take a look, and this is what you see. Start nystatin. Any thoughts? So no, this is perianal strep, caused by usually group A strep. It's a well-demarcated, beefy red lesion of the skin folds without any satellite lesions. Parents may report kind of blood streak stools, pruritus, and pain with defecation. You should swab this and send them any well-appearing child you can send home on amoxicillin 50 mg per kg per day once daily for up to 10 days. And they need kind of close follow-up because they have a lot of recurrences. This is commonly misdiagnosed and missed, which can lead to complications such as perianal abscess, fistula, sepsis, osteomyelitis, rheumatic fever, and toxic shock syndrome. So now that you've seen it, don't miss it. Your next one is a 4-year-old with a rash. They have a history of eczema, and you walk into the asthma room and you see this. Any thoughts? Maybe this will help more, or this. Topical steroids and mupirocin, go home. Morley shaking his head. So this is eczema herpeticum, which I almost missed in the downstate ER. It's characterized by pus-filled lesions and punched-out lesions overlying areas of eczema, and it spreads really rapidly, which is usually what the parents will say. These children can sometimes appear very ill or almost toxic, so those are obvious admissions for IV acyclovir. But also if you have any children that have extensive disease, involvement of the face or the periauricular areas, extensive mouth involvement that impairs oral intake, or signs of central nervous system involvement, you should admit them for IV antivirals. If the involvement is only like their hands or feet, maybe flexural folds, you can consider oral acyclovir or valcyclovir and strict kind of return precautions. And your last one is a 22-month-old with a pruritic rash. So mom says that she's kind of been itching for the past 2 days. She's had no vomiting, diarrhea, no trouble breathing, no allergies mom knows of. No one else in the house has this rash, no travel. She recently started this new detergent. Child has normal vital signs, clear oropharynx, no wheezing, abdomen soft, non-tender, and she kind of has these raised erythematous wheals all over the skin with excoriations. So what do we think this is? This is a pretty obvious one. Urticaria, yeah. You're gonna give Benadryl? So I put a soft kind of no on this one. It wouldn't be wrong, and one dose is probably not going to make a difference, but consider a second-generation H1 antihistamine in these children, such as Zyrtec or Claritin. With urticaria, allergic rhinitis, or allergic conjunctivitis, it has the same efficacy as Benadryl, and Zyrtec can be a once-daily dosing at home, which makes it easier for parents. Studies have shown that Benadryl, due to its sedating nature and other things we do not understand in crossing the blood-brain barrier, it impairs learning and school performance. And in younger children less than 2 can cause paradoxical agitation and is associated with new onset seizure. So again, any child with anaphylaxis, you're going to give epi, Benadryl, IV Benadryl, Dex, Pepcid, which is all supported with the American Academy of Allergy, Asthma, and Immunology in their 2020 systemic review. But simple cases of allergies where you may be sending them home on a course of antihistamines, consider a second generation H1 antihistamine over Benadryl and protect these children's brains. So lastly, I'm going to talk about a case that had me running around the PGY4 overnight. 7-year-old, past medical history of asthma, no intubations, came in for fever and cough for 4 days. Started having abdominal pain today with multiple episodes of vomiting. Mom didn't notice any wheezing. His exam, he was febrile to 102, tachy to 143, normal blood pressure, tachypnic, saturating 94% on room air. He was tired appearing, dry mucous membranes, lungs with decreased breath sounds at the bases, but no retractions, no wheezing. Abdomen was soft, non-tender. So the triad of fever, cough, and abdominal pain, what should this kind of make you think of? Let's get to the punchline. Just make you think of pneumonia. Children with cough and abdominal pain commonly have a lower lobe pneumonia. This child was ordered for Duoneb, Zofran, Dex, Cepheid, and Tylenol, and immediately vomits. So decision was made to put a line in, get labs, CBC and a comp, IV fluids, and a chest x-ray. His chest x-ray showed he had pneumonia and he was given ampicillin. Labs come back, he has a white count of 20, his glucose is 240, his anion gap is 19, his bicarb is 20. So we're kind of sitting there overnight saying, is this DKA? Is this new onset diabetes? Is this due to the Dex? But he kind of vomited up the Dex immediately. How much could he have absorbed? He's been vomiting, shouldn't his glucose be low? Is this due to something else? So we all know this, but DKA kind of criteria in children: hyperglycemia, blood glucose greater than 200, metabolic acidosis, so pH less than 7.3, and ketosis, so presence of ketones in the blood or the urine. Again, 2025 American Diabetes Association says that an elevated anion gap is no longer necessary for a DKA diagnosis. But right now, based on the labs we sent, all we kind of have is an elevated glucose. So we discussed with the family, he's had no weight loss, no polyuria, polydipsia, there's no family history, but he's kind of in the setting of having belly pain and vomiting in the setting of an infection, sent to VBG and a beta hydroxybutyrate and a repeat BMP. But in classic county fashion, the beta hydroxybutyrate never went into process, had to be added on, took 4 hours to come back. His labs show a pH of 7.23. His glucose kind of improved to 133 after fluids. He has a worsening anion gap, but his lactate is 5. So we're kind of attributing that all to the albuterol and the anion gap worsening due to lactic acidosis. Is this all in the setting of underfluid resuscitation? So he was given further IV fluids, was approaching 6 a.m. So the decision was made to call the PICU attending. And the PICU attending answers the phone and is immediately not concerned for DKA or diabetes. He says this is most likely hyperglycemia in the setting of critical illness. And he adds that the ER is really good about getting finger sticks. And so they see hyperglycemia a lot in a lot of these sick children. After the second bolus, repeat labs, his VBG and BMP are completely resolved. His beta hydroxybutyrate eventually came back on the floor as negative. His hemoglobin A1C was negative. He was admitted to the floors for pneumonia. So just a little bit about this. Stress hyperglycemia is common in the pediatric patient. Estimated 49 to 72% of children experience blood glucose concentrations greater than 150 while they're sick. And about 20 to 35% of children experience concentrations greater than 200. This develops due to increased gluconeogenesis relative to glucose clearance and development of insulin resistance. This process occurs due to increases in epinephrine, norepinephrine, glucagon, cortisol, growth hormone, and pro-inflammatory cytokines. And the purpose is to increase blood glucose concentrations to provide fuel for vital organs in the body at a time of increased stress. And while initially it may represent an adaptive response to improve the likelihood of survival, persistent hyperglycemia during illness may be harmful and overall has a higher mortality rate. Again, an elevated blood glucose and concern for DKA based upon history should always be explored. But if blood glucose over 200 in a pediatric patient with history not consistent with DKA, should consider more serious underlying infection as kind of the cause of hyperglycemia. And lastly, it wouldn't be a PEM lecture without discussing constipation. So we have a 2-month-old ex-full term, normal spontaneous vaginal delivery with no medical problems. Comes in with the parents for concern for constipation. They're grunting, they're red in the face, they're in distress prior to every bowel movement. Mom is breast and bottle feeding, but mostly bottle feeding now due to mom returning to work. Still stooling 1 to 2 times a day, soft, no blood, no vomiting. This is their first baby. And in between these episodes is happy, interactive, no other concerns. Benign exam without fissures. So is this baby constipated? Gonna give a glycerin suppository, send home. So no, this is infant dyschezia. It's fairly common. It's kind of caused by the failure to relax the pelvic floor during defecation effort. In addition, infants also have inadequate abdominal muscle tone to produce Valsalva maneuver. In clinical history, parents will usually describe this crying, red in the face, grunting. They're very distressed by this, but then there's soft stool and no blood. Infant dyschezia generally resolves spontaneously as the infant matures, and reassurance is all that's needed. Rectal stimulation is counterproductive and may do more harm in development of proper coordination and stooling, and suppository and laxatives are unnecessary. So thank you to all the faculty. Thank you to my residency class. I couldn't have done these last 4 years without you guys. Thank you to my family and friends and my favorite person. This is my nephew, if you don't know, for getting me through the past 4 years. He's taken after me in more ways than one, but everyone knows of these pictures which way. I hope he doesn't. And these are my references.